Right. Good evening, everyone. My topic is blood transfusion during ECMO. When and what? There are no financial sponsorships. The relationship between blood and ECMO has been like between hand and glove. Right from cardiopulmonary bypass to surgical ECMOs, bleeding has been a major issue from cavities and cannulas. And there are multiple problems during transfusion and mismatch. And therefore, there has been an extensive study of more than 20,000 articles in bibliography about ECMO literature. And therefore, most of the time, the blood bank directors have been on the panel for the ECMO management committee because blood is part and parcel of ECMO. There have been vast trials and literature trying to help in reducing the side effects of blood transfusions. The plan during my talk would be blood components, preparation and administration, and acute and chronic transfusion reactions. Now, blood administration, pre-oxygenator on ECMO, whole blood, packed red RBCs, exchange transfusion, and FFPs. Blood administration, post-oxygenators are platelets and cryoprecipitate. Now, blood products needed post-initiation are platelets, packed RBCs, FFPs, and cryo. Now, blood products. Fresh whole blood. The cellular component is 45%, the plasma is 55%, the hematocrit is 35%, anticoagulation are CPD, CPD2, CPDA. They store between 1 to 660 centigrade. It should be less than 72 hours ideally, and it contains platelets, granulocytes, and labile factors also. It will increase the hemoglobin, the clotting factors, and the volume. An adjustment of heparin is not required. And if it is usually given when there's a massive transfusion required, and massive transfusion means equivalent to blood volume of the person in less than 24 hours. It will cause high potassium because the potassium will be released from lyse RBCs. It will increase the acid and it will reduce the ionic calcium levels. Then PET RBCs. It is about only cellular component of right blood cells. The hematocrit is 70 to 80%. The anticoagulation is CPD, CPD2D, CPDA. It is stored between 1 to 6 degrees centigrade. It is good for up to 21 days to 35 days. Can be extended to 40 days, but that is not desirable. The volume is around 250 to 350 cc. The standard pediatric dose is 10 cc per kg, and the range is between 5 to 15 cc per kg in children. And the adult size is 1 unit, which raises the hematocrit to by 1.5%. Then it should be transfused when the hematocrit is lower. For VA ECMO, it should be less than 35% hematocrit, and in VV ECMO, it should be less than 45% hematocrit. It contains PET RBCs with a hematocrit between 55 to 70%. Then PET cell transfusion, it should be given over 1 hour. The dose for small kid is 5 to 15 ml per kg. Volume is roughly 250 to 300 ml. It should be preferably given through a central line. It will increase the hematocrit in adults. 1 unit will increase hematocrit by 3%. Adjustment of heparin dose is not required. It will cause high potassium, increase in acid levels, and decrease in ionic calcium. Then FFPs. FFPs are used to correct the coagulation abnormalities, such as fibrinogen level less than 100 milligram per deciliter, APT is more than 30 seconds, APTT more than 250 seconds. And it will dilute your hematocrit when given. It uses citrate to anticoagulate, so it will decrease the calcium levels. Primary indication is replacement of coagulation factors. It contains water, electrolytes, plasma proteins, and primarily albumin. It is frozen at 18 degrees centigrade. It is thawed on order. And after thawing, it expires in 24 hours. Standard dose is 10 cc per kg or 1 unit per 20 kg. It increases the factor activity by 20% unless DIC is there. Then cryo. Cryo is a more purified form of FFP. It contains fibrinogen, factor 8, factor 13, BWF, fibronectin, and a minimal amount of plasma protein. It is stored frozen and it is thawed on order. The standard dose is 1 unit for 10 kgs or 10 to 15 cc's per unit. And it will increase about 50 milligram deciliter of fibrinogen level. It should be given over 5 minutes. The dose is 15 ml or 1 unit per 10 kgs. The volume is 10 to 15 cc per unit. It should be thawed and expired within 4 hours. It is given through a central line. It will increase the fibrinogen level by more than 50 milligram per deciliter. And adjustment in the doses of heparin is required. Then platelet and platelet apheresis or platelet concentrate, it can be stored up to 5 days. The indication of thrombocytopenia, bleeding, invasive procedures, or for massive bleeding, the platelet apheresis is the RBCs are given back to the donor, and the volume is around 400 ml, and the dose is about half unit for less than 40 kg body weight, and 1 unit or more for more than 40 kg body weight. 5 to 10 ml per kg in the children is small, and it's stored at room temperature, and the shelf life is 5 days. Other blood products are antithrombin 3 concentrate. It inhibits the thrombin and factor 10A activity, thereby enhances the heparin activity over more than 100 times. And measuring of anti-10A levels is required for more precise management of heparin levels. The dosing formula is 120 into the percentage activity multiplied by kg in terms of units, and that is manufacturer dependent. Then granulocyte transfusions prepared at the time for immediate transfusions. There is no storage. It is indicated for severe neutropenia and failed antibiotic therapy and recovery from bone marrow transplants. Given for the donor is given a granulocyte colony stimulating factor and steroids. The complications are severe allergic reactions, and if irradiated, it's better to prevent graft versus host disease. The blood products administration during DIC, because DIC causes free thrombin, which is present in the blood during a infective or a septic environment, and therefore causes a disseminated microthrombi. The clinical signs are petechiae, and you try to treat the primary process. Heparin is used to inhibit the thrombin generation if there is ischemia, and on ECMO, under heparinization is the cause for DIC because of exposure to foreign surfaces. You have to correct bleeding with FFP, cryoprecipitate, platelet, and heparin, and do not turn the heparin off. Washed blood products. Packed RBCs and platelets are usually washed. It removes all except for a few traces of plasma. It is indicated to prevent recurrent or severe reactions, and it should be used within 24 hours. And during washing, you use 10 to 20% of the RBC volume because of washing. Leukocyte reduction filters, it can be used for RBCs, platelets, FFP, and cryoprecipitate. For others, leukocyte reduction filters are not used. It may reduce the RBCs by 5 to 10%, but it does not prevent graft versus host disease. Then transfusion complications. The transfusion complication can be divided into 3 main headings: acute transfusion reaction, chronic transfusion reactions, and transfusion-related infections. In acute transfusion reactions, hemolytic reactions, febrile reactions, allergic reactions, and transfusion-related acute lung injury, coagulopathy with massive transfusions, and bacteremia. The frequency of transfusion reaction, common one are febrile non-hemolytic transfusion reaction, allergic transfusion reaction. Other things are less common. Acute hemolytic reactions are 1 in 25,000. Anaphylaxis is 1 in 1,50,000 incidents, and delayed hemolytic reaction 1 in 2,500 reactions. Now, for acute hemolytic transfusion reactions, it occurs mainly because of incompatible RBCs are transfused into the recipient, and it causes an intravesical hemolysis. Symptoms occur within minutes of starting the transfusion and can occur with as little as 1 to 2 cc's of RBCs. Labeling error is the most common problem and can be fatal. Then symptoms of acute hemolytic transfusion reaction: high fever, chills, hypotension, back and abdominal pain, oliguria, dyspnea, dark urine, and pallor. What to do? Stop the transfusion, then look for the signs for CPR if required, then maintain an IV access and run the IV fluids, monitor and maintain the BP and pulse, give diuretics, obtain blood and urine for transfusion reaction workup, and send the remaining blood back to the blood bank. What will the blood bank do? We will check the paperwork to assure no errors, check plasma for hemoglobin, and do a direct antiglobulin test, repeat cross-match, repeat blood group typing, and blood cultures. Lab finding for AHTR, hemoglobinemia, hemoglobinuria, positive direct antiglobulin test, hyperbilirubinemia, and abnormal DIC panel. Monitoring you require clinical status and the vital signs, monitor the renal parameters, monitor the coagulation status, the DIC panel, PT, PTT, fibrinogen, D-dimers, FDP, antithrombin, platelet, etc. And monitor the sign for hemolysis by LDH, bilirubin, and heptaglobin. Then febrile non-hemolytic transfusion reactions. This is the rise of patient temperature of more than 1 degree centigrade associated with transfusion without other fever precipitating factors. It occurs with approximately 1% of PET RBC transfusion and approximately 20% of platelet transfusion. It is caused by allo antibodies directed against the HLA antigens, and you need to evaluate the acute hemolytic transfusion reaction and infection. What to do? Stop transfusion, use antipyretics, use steroids, use narcotics for chills, and for future consideration, you prevent reactions by leukocyte filter, use single donor platelets, use fresh platelets, and you use washed RBCs and washed platelets. Then allergic non-hemolytic transfusion reaction. The etiology is due to plasma proteins or blood preservatives or anticoagulants used for storing the blood. It is best characterized when IgA is given to an Ig deficient patient. It presents with urticaria and wheezing. The treatment is for mild reaction, you can continue with antihistaminics. For severe reaction, stop transfusion and may require steroids or epinephrine. And prevention is for pre-medication with antihistamines. Then transfusion-related acute lung injury occurs when plasma containing transfusions and there are donor antibodies causing pulmonary edema. For this severe respiratory distress, treatment is steroid oxygen therapy and mechanical ventilation. The recovery is very good. The clinical syndrome is similar to ARDS, occurs within 1 to 6 hours after receiving plasma and caused by WBC antibodies present in the donor that results in pulmonary leukostasis, and the treatment is supportive and has low mortality. Massive transfusions. In massive transfusion, coagulopathy may occur after transfusion of massive amount of blood. It is caused by failure to replace plasma, and you look for electrolyte abnormalities because of preservatives. Chronic transfusion reactions, they are alloimmunization, transfusion-associated graft versus host disease, iron overload, and transfusion-transmitted infections. Alloimmunization can occur with erythrocytes or platelets. In erythrocytes, the antigen disparities of minor antigens like KEL, DEFI, KID, or D, T, E, etc. in sickle patients. In platelets, is due to HLA antigens and may reduce the alloimmunization by leukoirradiation since the WBCs are present with HLA antigens. Transfusion-associated graft versus host disease, mainly seen in infants with bone marrow transplants and severe combined immunodeficiency disorders. It results from an engraftment of donor lymphocytes from an immunocompetent donor to an immunocompromised host. Symptoms are diarrhea, skin rashes, and pancytopenia, and it is usually fatal. There is no treatment. Prevention is irradiation of the donor cells. Then graft versus host diseases occurs with fresh whole blood transfusion. Donor and recipient share HLA types. Symptoms occur in 8 to 10 days post-transfusion. in terms of bone marrow aplasia and pancytopenia. There is no known treatment. Mortality is 90%. Prevention is through irradiations of RBCs and platelet, and we destroy the T lymphocytes. Then blood bugs, hepatitis C, hepatitis B, HIV, cytomegalovirus. The cytomegalovirus occurs with fresh whole blood transfusions, and they are leukocyte-borne viral infections, and transfusion occurs via donor monocytes and can cause hearing or vision loss and developmental delays. Bacterial contamination, more common and more severe with platelet transfusions, and the organisms are Staph, Strep, Yersinia, and Enterobacter. Mostly can be others also. The risk increases as blood products ages. Use fresh products for immunocompromised patients. Prevention of all these reactions for febrile transfusion reaction, leukocyte depletion filter or single platelet apheresis. For alloimmunization, same filters and single platelet apheresis. Cytomegalovirus, no particular specific prevention. Filters may help, may not help. Transfusion-related graft versus host disease, gamma radiation. Differential centrifusion or second centrifusion may help in massive transfusion. So therefore, the second centrifuge will have further reduction in plasma by around more than 70%. In all, in short, management is whenever there is a reaction, stop the transfusion, use antihistaminics, restart the transfusion slowly if there's a minor symptoms and there are no other signs of severe reaction. For prevention, routine pre-medication is not helpful. For recurrent reaction, you may use pre-medication of plasma depletion of washed RBCs and washed platelets. Then clinical management of patient for on ECMO for bleeding. You maximize your clotting factors and accept lower ACTs levels. Use a tag more frequently. Consider antifibrinolytics or use recombinant factor 7. Decrease heparin drip or stop if completely. If nothing is working, consider surgical intervention and circuit replacement to be ready and anticipated. If there's a bleeding from cannulation site, hold continuous pressure for 20 to 30 minutes. Have cannulating surgeons place another suture. Use fibrin glue and other clotting agents. If no response, tranexamic acid and aprotonide. Bleeding, check for coagulation labs and give blood products, direct pressure or topical agents. Lab tests of platelet functions, tag and factor 10A activity. For consider the doses of heparin, consider aminocapric acid or Novosarin. Take home messages for transfusion reaction. The acute hemolytic transfusion reaction can be fatal. Whenever there's a reaction, stop the transfusion, monitor for symptoms and complete evaluation. Febrile non-hemolytic transfusion reactions are diagnosis or exclusion. Trials like ARDS. For prevention of chronic transfusion reactions, use filters, double centrifuge, irradiation or pre-medication.